Welcome to the Deep Dive, your shortcut to being truly well-informed. Today, we're embarking on a really crucial journey right into the heart of nursing practice, mastering health assessment and physical examination.
Yeah, we've dug into fundamentals of nursing to pull out those key insights for you.
Exactly. We want to equip you with the essential knowledge you need for, real-world application.
And it's so important. Think of a comprehensive assessment.
Yeah.
It's not just collecting data, right? It's about understanding the whole patient.
Mm-hmm.
It's about picking up on subtle cues, telling normal from abnormal, and making those critical clinical judgments. That's what underpins safe, competent care. It's honestly transformative.
So on this deep dive, we'll explore the why behind these assessments, look at the core techniques, inspection, palpation, percussion, and auscultation, IPPA for short.
ABPA, yeah.
And then we'll walk through a systematic head-to-toe exam system by system. We'll keep connecting it back to real situations and those competencies you need out there.
Sounds like a plan.
Okay, so let's start with the basics. Why do nurses even do physical exams? It feels like more than just a routine checkup sometimes.
Oh, definitely. The reasons are pretty diverse. It could be an initial evaluation, like triage in the ER,
Right.
or routine screenings, determining eligibility for certain services, or the fundamental admission assessment when someone comes into the hospital.
And the data we gather, what does it really allow us to do?
Well, that data is incredibly powerful. It helps you spot health patterns, see how patients are responding to treatments, get that vital baseline info,
Mm-hmm.
and sometimes confirm or even challenge what the patient is telling you subjectively. Ultimately, it all drives your nursing diagnoses and your clinical decisions.
Can you give an example, maybe differentiating between types of assessment?
Sure. Let's say you have a patient having a severe asthma attack. Your priority isn't a full head-to-toe right then, is it?
No, definitely not.
Right. Your immediate focused assessment is going to zero in on their pulmonary and cardiovascular status. You need to act fast. But once they're stable, then you can broaden your scope and do that more comprehensive assessment. It really shows how you adapt your approach based on the situation.
That makes sense. And what about the patient's background? How does that play in?
That's a huge piece. Cultural awareness is absolutely foundational. You have to approach every patient with what we call cultural humility.
Cultural humility, meaning?
Meaning acknowledging you don't know everything about their culture and being willing to adapt your methods to respect their unique background. It's about recognizing common traits or health risks in certain populations without stereotyping.
Right, avoiding stereotypes is key.
Exactly. And understanding variations in physical traits like skin differences or even musculoskeletal structure. Doing this well leads to much higher quality patient-centered care.
So practically, that might mean thinking about how their culture views illness.
Yes, or their communication preferences, health beliefs, family roles, even nutritional practices.
Yeah.
All these things can impact how you assess and interact.
And there's a really important practical point, too, about gender, right?
Absolutely crucial. If you, as the examiner, are of the opposite gender to the patient, you must ensure a witness is present. This could be another staff member of the patient's gender, or sometimes a culturally appropriate family member. It's about respect, but also safety and professionalism.
Okay, good point. So before we even start touching the patient, preparation seems key.
It really is. Proper prep sets the stage for a smooth, uninterrupted, and most importantly, accurate examination.
And safety comes first, I imagine.
Always. You're responsible for identifying potential latex allergies, for instance. There are different types, and you need to know when to use non-latex alternatives.
Right.
And a hard rule.
Yeah.
Never, ever leave a confused or combative patient alone during an exam. That's non-negotiable.
What about the environment itself?
You want it private? Well-lit, good lighting is essential. Quiet and warm. That applies whether you're in a hospital room, a clinic, or even doing a home visit.
And equipment.
Have everything ready beforehand. Your stethoscope, blood pressure cuff, thermometer, pen light, maybe a Snellen chart. Oh, and always warm your stethoscope diaphragm before putting it on someone's skin. It's a small thing, but it matters for comfort. And check that everything works.
Patient comfort is a big theme here.
Huge. Make sure they've had a chance to use the restroom. An empty bladder makes an abdominal exam much more comfortable and accurate. Proper dressing and draping are also vital for privacy and keeping them warm. Give them time. Check in with them.
And what about their mindset? Exams can be stressful.
Absolutely. Psychological preparation is just as vital as the physical. Patients are often anxious. Explain clearly what you're going to do, why you're doing it, step by step.
Adapt your language too, I guess.
Yes, tailor it to their understanding level. Encourage questions. Keep your approach open, professional, but relaxed. That helps build trust. Watch their emotional responses, facial expressions, body language.
And pacing.
Crucial, especially for patients who are weak or elderly. Don't rush them. You get much more accurate findings when the patient is cooperative and comfortable.
Let's talk positioning. Does it really matter how the patient is positioned?
Oh, definitely. It depends entirely on what you need to assess and what the patient can tolerate. Sitting up is great for checking lung expansion and the upper body.
Okay.
Lying supine, flat on their back, helps relax the abdominal muscles and gives easy access to pulse sites. But you always have to consider their strength, mobility, breathing status, even their age.
So someone short of breath wouldn't tolerate lying flat for long.
Exactly.
Hmm.
Or lying prone on their stomach. You have to adapt. Other positions like dorsal recumbent, lithotomy, lateral, or knee chest are used for specific exams like pelvic or rectal exams, but they have their own limitations and comfort considerations.
Any practical tips for positioning?
Always help patients get on and off the exam table safely. That prevents falls. Elevating the head of the table, maybe 30 degrees, often makes lying down more comfortable.
Good tip.
And try to be organized. Minimize how many times you ask them to change position, do all the sitting assessments together, then all the supine ones, and so on. It's less tiring for them.
Okay, now, here's where it gets really interesting, I think. Adapting the assessment for different age groups. It's not one size fits all, is it?
Not at all. Children, adolescents, older adults, they each need a tailored approach.
Let's start with kids.
With children, building trust is everything. Start in a non-threatening way. Talk to them, play a little, observe them before you start touching.
Okay.
And when you do the physical part, maybe start with their hands or feet, the periphery, and move towards the center, like their chest, last. That's often less intimidating.
And getting the history.
For infants and young kids, you'll get most of it from the parents. Use open-ended questions. Watch how the parent and child interact. That tells you a lot, too. Offer support to the parents. Exams can be stressful for them, too.
What about adolescents?
Treat them more like adults. Respect their developing independence, and crucially, ensure confidentiality. Talk with the parent first, perhaps, but then make sure you speak with the adolescent alone. They need that private space to discuss sensitive issues.
And older adults.
With older adults, you need to be aware that signs and symptoms of illness can be subtle or atypical. They might not present like a textbook case.
Right.
Your assessment should definitely include their functional status, ADLs, activities of daily living like bathing and dressing, and IADLs, instrumental activities like managing finances or medications.
And fatigue.
Be super alert for signs of fatigue, sighing, grimacing, leaning for support. Pace the exam according to their endurance. You might need to break it up into smaller sessions.
So these adaptations are all about...
They're all about patient-centered care, making sure you get the most accurate information possible so you can make sound clinical decisions.
Okay, fantastic foundation. Now let's unpack those 4 core skills. IPPA, inspection, palpation, percussion, auscultation are our main tools.
Exactly. Let's start with inspection. This is really the art of careful observation using your sight, primarily.
Just looking, basically.
Well, yes, but it's deliberate, focused looking. You have to practice to really see all the possible cues. Good lighting is key. Systematically look at each body area for size, shape, color, symmetry, position, any abnormalities.
And comparing size.
Always compare side to side for symmetry. And interestingly, inspection also involves your sense of smell olfaction.
Smell.
Yes. Certain body odors can be very characteristic of underlying conditions. Think of a sweet, fruity breath in diabetic ketoacidosis, or maybe an ammonia smell with kidney failure, or even a specific foul odor from a wound infected with Pseudomonas.
Huh. Okay, so inspection is more than just looking. What's next? Palpation.
Palpation. Using your sense of touch. You're feeling the skin, tissues underneath, muscles, bones, assessing things like temperature, moisture, texture, turgor.
Turgor, that's the skin's elasticity, right?
Exactly. You check for tenderness, thickness, any distension, or masses. Different parts of your hand are better for different things.
Like how?
Well, the pads of your fingers are best for fine details, like texture, size, and consistency. The back, or dorsum, of your hand is more sensitive to temperature. The palm, or ulnar surface, is good for feeling vibrations, like fremitus.
Got it. Any tips for doing palpation well?
Warm hands. Nobody likes cold hands on their skin. Keep your fingernails short. Be gentle, slow, deliberate. Help the patient relax. Maybe ask them to take deep breaths. Ask if any areas are tender before you start, and palpate those areas last.
And there's light versus deep palpation.
Right, light palpation is very gentle, just depressing the skin about 1 centimeter. Deep palpation uses more pressure, maybe 4 centimeters deep, to assess underlying organs. Needs more skill and caution.
Okay. Then there's percussion, tapping.
Yep. Percussion involves tapping the patient's skin with your fingertips. This creates vibrations that travel through the underlying tissues.
And the sound tells you something.
Exactly. The character of the sound reflects the density of the tissue underneath. Denser tissue, like bone or a solid organ, produces a quieter, flatter sound. Air-filled spaces, like the lungs, produce a louder, more resonant sound.
So it helps locate things.
Precisely. It helps you locate organs, determine their size and shape, map out edges, or identify if there's unexpected fluid or air where it shouldn't be.
Makes sense. And the last one, auscultation, listening.
Auscultation. Listening to sounds produced by the body. Usually this means using a stethoscope to hear internal sounds, heart, lungs, bowels.
What creates those sounds?
Mostly the movement of air, blood, or gastric contents through organs. Your job is to learn what's normal and what's abnormal.
And the stethoscope bell versus diaphragm.
The bell is best for low-pitched sounds, think some heart murmurs, or vascular sounds like brutes. The diaphragm is better for high-pitched sounds like normal breath sounds and bowel sounds.
Listening seems like it requires focus.
Absolutely. You need a quiet environment. Listen systematically. Learn to filter out extraneous noise. Pay attention to the sound's characteristics, its frequency or pitch, high-low, loudness, soft-loud, quality like gurgling or blowing, and duration, how long it lasts. It takes practice, lots of practice.
Okay, IPPA inspection, palpation, percussion, auscultation. Got it. Now let's apply these. Let's start that head-to-toe journey.
Right. We begin with the general survey. This starts the second you first see the patient. It's your overall impression.
What are you looking for?
You're gathering initial cues about their general health state, their level of independence, body image, emotional state, even developmental status. Look at their apparent age versus their stated age, gender, race. Note any obvious signs of distress, grimacing, shortness of breath, anxiety.
Body type, posture.
Exactly. How they move, their gait, their hygiene and grooming, does it seem appropriate? How they're dressed, any noticeable body odors, their effect of mood, facial expressions, and how they speak. Is it clear, coherent?
This is also where you might pick up on sensitive issues, right? Like abuse.
Yes. Critical thinking is vital here. For potential patient abuse, you're looking for both physical signs, maybe unexplained bruises, discharge, malnutrition, and behavioral signs like fear of a caregiver or inconsistent explanations for injuries.
And what do you do if you suspect something?
Ensure privacy for interviewing. Ask direct, non-judgmental questions. And remember, nurses are mandated reporters. You have a legal obligation to report suspected abuse or neglect.
What about substance abuse?
Similar process. Look for physical clues, agitation, poor coordination, needle marks, specific skin changes with certain drugs, and behavioral clues, missed appointments, vague pain complaints, lost prescriptions, frequent ED visits.
Are there tools for screening?
Yes, like the CAGE questionnaire for alcohol.
Yeah.
Have you ever felt you should cut down? Have people annoyed you by criticizing your drinking? Have you ever felt guilty? Have you ever needed an eye-opener drink first thing? There are also tools for adolescents.
Okay, after the general survey.
Vital signs: temperature, pulse, respirations, blood pressure, oxygen saturation. And importantly, assess pain, the fifth vital sign. Do this before you have the patient change positions, as moving can affect the readings.
Height and weight too.
Yes, they reflect nutritional status and can show important trends. Significant weight loss, say more than 5% in 6-12 months without trying, needs investigation. Same with sudden weight gain, which could be fluid retention. Use the right scale standing, chair, bed scale, and always zero at first.
Got it. Let's move to the skin, hair, and nails, the integumentary system.
A really important system. The skin tells you so much about oxygenation, circulation, nutrition, hydration.
So what do you ask the patient first?
Ask about any history of skin problems, dryness, rashes, lesions, sores that don't heal. Ask about sun exposure habits, allergies. Also consider the risk factors for skin breakdown, like immobility or incontinence.
And then inspecting and palpating.
Use good lighting, preferably daylight. Do a full sweep. Look at the color. That they pink, pale, jaundiced, cyanotic, flushed. Palpate for temperature using the back of your hand. Is it warm, cool, clammy? Check moisture. Is it dry, oily? Texture smooth, rough.
And turgor, how do you check that?
Gently grasp a fold of skin, usually on the forearm or under the clavicle, and lift it. Then release. It should snap back quickly. If it stays tented, that suggests dehydration.
What about spots or lesions?
Note any vascular changes like petechiae, those tiny red or purple spots. Describe any lesions carefully. Color, locations, size, shape. Type: it was flat like a mentule, raised like a papule, fluid-filled like a vesicle.
And skin cancer is a major concern.
Absolutely. Remember the ABCDE mnemonic for assessing moles or lesions that might be cancerous. Asymmetry, border irregularity, color variation, multiple colors, diameter larger than 6 millimeter, a pencil eraser, and evolving or changing over time.
Can you briefly describe the main types?
Sure. Basal cell carcinoma is most common, often looks like a pearly bump. Squamous cell is often red, scaly, can spread. Malignant melanoma is the most dangerous, often dark or multicolored, irregular, and can metastasize quickly. Early detection is key.
Which leads to patient teaching.
Definitely. Teach monthly skin self-exams. Stress sun safety. Sunscreen SPF 30 plus protective clothing, avoiding peak sun hours.
Okay. Hair and scalp.
Inspect the hair for color, distribution, any unusual patterns of loss, quantity, thickness, texture, lubrication. Look closely at the scalp for lesions, scaling, or signs of lice. Check for nits, those tiny white eggs, especially behind the ears and at the nape of the neck.
And nails.
Nails reflect overall health, too. Look at the nail plate. It should be smooth, slightly convex. Check the color under the nail. Palpate for firmness. Abnormalities like clubbing, where the nail angle increases, suggest chronic low oxygen. Bose lines are horizontal grooves from illness.
Any specific teaching for nails?
General good hygiene. And a really critical point, patients with diabetes or peripheral vascular disease should not soak their feet or nails, as it increases infection risk. They often need professional podiatry care.
Good point. Okay, moving up. Head, eyes, ears, nose, and throat heat. Let's start with the head.
Inspect the head for position. Is it upright, tilted, size, shape, contour? Look at the face for symmetry. Any tremors? Palpate the skull for any nodules or tenderness. Check the temporal mandibular joint, TMJ, for smooth movement, clicking, or tenderness.
Eyes next. Seems like a lot to assess here.
It is. You're checking visual acuity, how clearly they see. Visual fields, peripheral vision. Extraocular movements, how the eyes move together, and all the structures.
How do you test acuity?
Usually with a Snellen eye chart, standing 20 feet away. 20/20 is normal. 20/40 means they can see at 20 feet what someone with normal vision sees at 40 feet. If they can't read the chart, you test if they can count fingers, see hand motion, or perceive light.
And eye movements.
Have them follow your finger or a pen light through the 6 cardinal directions of gaze, making an H pattern. Watch if their eyes move together smoothly and parallel. Note any nystagmus, that involuntary shaking or jerking of the eyes.
Then the external parts.
Inspect eyelids for position, drooping, apoptosis, redness, swelling, lesions like styes. Look at the conjunctiva, the lining inside the lid, and the sclera, the white part. Should be clear, white, without excessive redness or discharge. Check the cornea for clarity.
Pupils are key, right? PERRLA.
Yes, PERRLA sums it up. Pupils equal, round, reactive to light, both direct and consensual. When you shine light in one eye, the other should also constrict. And accommodation. Pupils constrict and eyes converge when focusing on a near object. Assess size, shape, and equality first.
Okay. What about ears?
Assess hearing first. The whispered voice test is common. Stand behind them, whisper random numbers or words, see if they can repeat them.
And using an otoscope.
You'll learn the proper technique. Gently pull the auricle up and back for adults, down and back for infants to straighten the canal. Look at the ear canal and the tympanic membrane, the eardrum. It should be pearly gray, translucent.
Any specific hearing tests?
Tuning forks are used for the Weber and Rinn tests. Weber tests for lateralization. Does the sound seem louder in one ear? Rinn compares air conduction versus bone conduction. Normally, air conduction is heard about twice as long as bone conduction, ACBC. These help differentiate types of hearing loss.
Good to know. On to the nose and sinuses.
Inspect the external nose for shape, symmetry, any deformities. Check if both nostrils or nares are patent. Can they breathe through each one?
And inside.
Use a pen light. Look at the nasal mucosa, the lining. Note its color. Is it pink and moist? Normal. Pale and boggy with clear discharge allergies. Red and swollen with yellow-green discharge, infection. Look at the septum for deviation. Palpate the frontal and maxillary sinuses for tenderness.
Mouth and pharynx.
Inspect the lips for color, moisture, lesions. Look inside at the buccal mucosa, cheeks, gums, teeth, any inflammation, bleeding, decay. Inspect the tongue, color, texture, symmetry, movement. Look at the hard and soft palate. Have them say, ah, and watch the uvula and soft palate rise symmetrically. Check the tonsils and the back of the pharynx for redness or exudate.
Patient teaching for oral health.
Good oral hygiene basics, brushing, flossing, regular dental checkups. Also, awareness of signs of oral cancer, especially sores that don't heal, which are increasingly linked to HPV.
Okay, let's move down to the neck.
Here you're assessing neck muscles, lymph nodes, the thyroid gland, trachea, and the carotid arteries, which we'll cover more under vascular.
Muscles first.
Check for symmetry of the sternocleidomastoid and trapezius muscles. Assess range of motion. Can they flex, chin to chest, extend, look up, rotate, look side to side, and laterally bend ear to shoulder?
Lymph nodes seem important.
Very. They're part of the immune system. Palpate them methodically using the pads of your fingers in a gentle circular motion. There's a sequence. Occipital, back of head, postauricular, behind ear, preauricular, front of ear, submandibular, along jaw, submental, under chin, cervical chains, supraclavicular, above collarbone.
What's normal versus abnormal?
Normally, you might not feel them easily, or they feel small, soft, mobile, and non-tender. If they're enlarged, hard, fixed, not movable, or tender, that usually indicates inflammation, infection, or possibly malignancy nearby.
Thyroid gland.
Inspect the neck as they swallow. Look for any visible enlargement or asymmetry. Palpate gently from behind or the front, feeling for size, shape, consistency, tenderness as they swallow again.
And the trachea.
Check that it's midline. Palpate gently on either side. Deviation can indicate serious issues like a collapsed lung, pneumothorax.
Okay, thorax and lungs next.
Start by considering risk factors. Smoking history is huge, obviously. Exposure to pollutants, secondhand smoke. Inspect the chest, front and back. Look for shape, symmetry, any deformities like barrel chest. Check the spine's position, any scoliosis, kyphosis. Note the slope of the ribs. Watch their breathing pattern, any use of accessory muscles, retractions between the ribs, or bulging. That indicates increased effort.
Palpation.
Palpate for any lumps, masses, tenderness. Check chest excursion. Place your hands on their back, thumbs pointing towards the spine. Ask them to take a deep breath and feel for symmetrical expansion. And tactile fremitus, that vibration thing.
Right. Have them say 99 repeatedly while you systematically palpate the chest wall with the palm of your hand. Feel for the vibration. It should be roughly symmetrical. Increased fremitus can mean consolidation, like pneumonia. Decreased fremitus might suggest air or fluid in the pleural space.
Okay. Then auscultation is key here.
Absolutely. Listen systematically over all lung fields, anterior and posterior, comparing side to side. Identify normal breath sounds. Vesicular, soft, low-pitched, heard over most lung fields. Bronchovesicular, medium pitch, heard near main bronchi. And bronchial, loud, high-pitched, heard over the trachea.
And the abnormal sounds, adventitious sounds.
Yes. Crackles or rails, popping sounds, often heard on inspiration, associated with fluid and alveoli. Raunchy, low-pitched, snoring, gurgling sounds suggest secretions in larger airways. Wheezes, high-pitched musical sounds caused by narrowed airways, common in asthma. Stridor, a loud, high-pitched crowing sound, indicates upper airway obstruction and emergency.
Wow, lots to listen for. Teaching points for lungs.
Recognizing warning signs of lung cancer, persistent cough, sputum with blood, chest pain. For asthma patients, teaching about triggers, proper inhaler use using a peak flow meter.
Okay, moving to the heart. Critical assessment area.
Definitely. Especially if you suspect a life-threatening condition. Start with inspection and palpation. Position the patient appropriately, maybe supine with head elevated slightly. Identify the key landmarks on the chest wall. Angle of Louis, then the valve areas aortic, second right intercostal space, pulmonic, second left, tricuspid, lower left sternal border, and mitral or apical, fifth left intercostal space, midclavicular line.
What are you looking for?
Look for any visible pulsations or lifts, heaves. Palpate these areas, especially the apical area, for the point of maximal impulse, or PMI. It's usually a gentle tap. Note its location.
What if it's displaced?
It might suggest the heart is enlarged. It can be harder to find in older adults or muscular overweight individuals. Also, palpate for thrills, that purring vibration we mentioned, which indicates a significant murmur.
Then auscultation.
Yes. Quiet room is essential. Listen systematically over all 4 valve areas, plus Erb's point, third left intercostal space. Use both the diaphragm and the bell. First, identify S1 and S2, the lub-dub. S1 is louder at the apex, mitral area. S2 is louder at the base, aortopulmonic areas.
Rate and rhythm.
Count the apical pulse rate for a full minute. Is the rhythm regular or irregular? If irregular, check if there is a pattern. Note any skipped beats or extra beats. If you suspect an irregular rhythm, compare the apical rate with the radial pulse rate simultaneously. A difference is called a pulse deficit.
What about extra heart sounds?
You might hear an S3, a ventricular gallop, sounds like Kentucky, often heard in heart failure. Or an S4, an atrial gallop, sounds like Tennessee. Heard when the atria contract against a stiff ventricle, may be due to hypertension.
And murmurs?
Murmurs are those swishing or blowing sounds caused by turbulent blood flow, often due to faulty valves. You need to describe them carefully. Timing, systolic between S1, S2, or diastolic between S2, S1. Location, where is it loudest? Radiation, does it spread elsewhere? Loudness, graded 1 to 6, grade 4 and up, usually have a palpable thrill. Pitch, high-low, and quality, blowing, harsh, rumbling.
Lots to analyze there. Teaching for heart health.
Huge focus on risk factor modification. Diet, exercise, smoking cessation, stress management, discussing preventive measures like blood pressure control, cholesterol management, maybe low-dose aspirin if appropriate.
Okay, connected to the heart is the vascular system.
Right. Start with blood pressure again, check both arms, especially on initial assessment. A significant difference might indicate arterial narrowing on one side.
Carotid arteries.
Inspect the neck for visible pulsations. Then palpate gently, one side at a time, to avoid cutting off blood flow to the brain. Feel for the pulse strength and contour. Then auscultate with the bell of your stethoscope over the carotid artery. Listen for a brood, that swooshing sound indicating turbulent flow due to narrowing stenosis. Normally, it should be silent.
Jugular vein.
Assess for jugular venous distension, JVD. Have the patient lie down with the head of the bed elevated 30-45 degrees. Turn their head slightly away from you. Look for the pulsation of the internal jugular vein. Note how high the pulsation extends up the neck. Remember, jugular pulses are visualized, not palpated. Distension suggests increased central venous pressure, often seen in heart failure.
Then peripheral vessels.
Yes. Assess blood flow to the extremities. Palpate peripheral pulses. Radial, brachial, femoral, popliteal, behind knee, posterior tibial, behind ankle bone, and dorsalis pedis, top of foot. Check for presence, strength, use a scale, for example 0 to +3, equality and symmetry between sides. If a pulse is hard to feel, use a Doppler ultrasound stethoscope.
And signs of perfusion.
Look at skin color, pink, pale cyanotic, temperature, warm, cool, and capillary refill. Press nail bed, should pink up in 3 seconds. Check for edema, swelling. Any skin changes like hair loss on legs can indicate poor arterial flow, or ulcers. Look for clubbing of fingernails, suggests chronic hypoxia.
Veins too.
Inspect for varicose veins. Palpate for tenderness, warmth, or redness along a vein, which could indicate phlebitis, inflammation. Check for peripheral edema. Press gently over bony areas like the shin or ankle. Note if an indentation remains, pitting edema, and grade its severity.
Okay, moving into more sensitive areas now. Female genitalia and reproductive tract.
Absolutely. Approach is key here. Calm, professional, respectful. Explain everything. Acknowledge potential cultural sensitivities. Ensure privacy with draping. And remember the need for a chaperone, especially for male examiners. The usual position is lithotomy, but adapt if needed, ample sideline.
What do you expect?
Inspect the external structures, pubic hair distribution, the labia majora and minora skin characteristics, any lesions, swelling, the clitoris, the urethral orifice position, any discharge, redness, the vaginal orifice, the perineum and anus.
Self-examination.
Teach genital self-examination, looking for any bumps, sores, blisters, warts, unusual discharge, which could indicate STIs.
Internal exams.
That's usually done by advanced practitioners using a speculum to visualize the cervix and collect pap tests. But nurses assist and provide support.
Teaching points here.
Emphasize HPV vaccination, regular gynecological exams and pap tests according to guidelines, safe sex practices, and STI prevention.
Okay. Male genitalia. Similar considerations.
Yes, potential for embarrassment. Again, a straightforward, gentle, explanatory approach helps. Observe sexual maturity rating based on penis testis size, scrotal changes, pubic hair. Inspect the penis shaft and glands for lesions, nodules, swelling, inflammation. If uncircumcised, retract the foreskin if possible to inspect the glands, then always replace it. Check the urethral meatus for position and discharge. Palpate the shaft gently for tenderness or hardness.
Scrotum.
Inspect for size, shape, symmetry. Look for lesions, swelling, edema. Palpate each testicle gently between thumb and forefingers. They should feel smooth, rubbery, ovoid, without lumps. Palpate the epididymis on the back of the testicle. It feels softer, comma-shaped. Important not to mistake this for a lump.
Testicular cancer is a big concern for young men.
Huge. It's most common between 18 and 34. Often presents as a painless lump. Early detection dramatically improves outcomes. This makes teaching testicular self-examination, TSE, absolutely vital.
How do you teach TSE?
Explain they should do it monthly, maybe after a warm shower when the scrotum is relaxed. Gently roll each testicle between the thumb and fingers of both hands. Feel for any hard lumps, bumps, or changes in size, shape, or consistency. Emphasize that one testicle might be slightly larger or hang lower, that's normal, but any new lump needs checking out immediately.
Anything else in the male exam?
Check the inguinal region for bulges that might indicate a hernia, especially when the patient strains or coughs. Palpate for enlarged inguinal lymph nodes.
And the rectum and anus.
Important for both sexes, primarily for detecting colorectal issues and, in men, prostate problems. Gently spread the buttocks to inspect the perianal area and sacrococcygeal area, tailbone, for skin characteristics, lesions, hemorrhoids, fissures, inflammation, rashes. Digital rectal examination is usually performed by advanced practitioners, but you might assist.
Key teaching here relates to screening, right?
Exactly. Outline the American Cancer Society guidelines for colorectal cancer screening options like stool tests, FOBT, FIT, DNA, sigmoidoscopy, colonoscopy, starting typically at age 45 for average risk individuals. For men, discuss prostate cancer screening, PSA blood test, DRE, usually starting around age 50 or earlier for higher risk groups. Emphasize warning signs like changes in bowel habits or blood in stool.
Almost there. Musculoskeletal system.
This assessment often gets integrated throughout the exam or during routine care. Focus is on joint motion, muscle strength, and overall function. Start by observing their gait as they walk in. Is it smooth, coordinated? Note posture alignment, spinal curves. Look at extremities for size, symmetry, any deformities.
Range of motion, ROM.
Assess major joints. Ask the patient to move the joint through its full range first, active ROM. If they can't, you might gently support and move the joint yourself, passive ROM, feeling for resistance or pain. Note any limitation, stiffness, swelling, or crepitus, a grating sound feel. Compare sides.
And muscle tone and strength.
Assess muscle tone by feeling the muscle's resistance to passive stretch when it's relaxed. Is it normal, increased hypertonicity, or decreased flabby hypertonicity? Test muscle strength by having the patient move against your resistance. Grade it on a 0 through 5 scale. 0, no contraction, 5, full strength against resistance. Compare sides for symmetry. Note any muscle atrophy, wasting.
Teaching for musculoskeletal health.
Big focus on osteoporosis prevention, especially for women. Discuss screening, bone density tests, importance of weight-bearing exercise, adequate calcium and vitamin D intake, and using proper body mechanics to prevent injury.
Okay, last but definitely not least, the neurological system.
A vast system. Controls everything from movement and sensation to thought, speech, memory. Assessment is often integrated throughout. Start with mental and emotional status. You gather a lot just by interacting with the patient.
Formal tools.
The Mini Mental State Examination, MMSE, is a common tool to screen for cognitive impairment. It assesses orientation, registration, attention, calculation, recall, and language. Scores can suggest mild, moderate, or severe impairment.
And delirium. You mentioned it's critical to recognize.
Absolutely critical. Delirium is an acute disturbance of consciousness, a change in cognition like attention, memory, orientation that develops over a short period, hours to days, and tends to fluctuate. It always has an underlying physiological cause like infection, medication side effect, dehydration. It's not normal aging. It's often reversible if the cause is treated. Children and older adults are particularly vulnerable. We have to distinguish it from dementia.
How do you assess level of consciousness, LOC?
It's a continuum from fully alert and oriented to unresponsive. The Glasgow Coma Scale, GCS, provides an objective score. It assesses 3 areas: eye-opening, spontaneous to none; best verbal response, oriented to none; and best motor response, obeys commands to none. Scores range from 3, deep coma, to 15, fully alert.
What if they don't respond to voice?
You might need to elicit a pain response, like nail bed pressure. Observe their motor response. Do they withdraw, show abnormal posturing, decorticate or decerebrate, or have no response, flaccid?
Other aspects of mental status.
Observe their behavior, appearance, mood. Assess intellectual function, memory, immediate recall, recent events, remote past. Knowledge base, abstract thinking. Can they interpret proverbs? Association, judgment. Always be culturally sensitive and don't mistake hearing loss for confusion. Assess language fluency, tone, word choice. Note any aphasia, difficulty understanding or expressing language.
Cranial nerves.
There are 12 pairs. You test their specific functions, like olfactory 1 for smell, optic 2 for vision, facial 7 for facial expressions and taste, vestibulocochlear for hearing and balance, and so on. The mnemonic helps. On old Olympus's towering tops, a Finn and German viewed some hops.
Sensory function.
Test primary sensations with the patient's eyes closed. Check pain, sharp versus dull, temperature if needed, light touch, cotton wisp, vibration, tuning fork on bony prominences, and position sense. Proprioception, move their finger or toe up, down, ask which way. Compare sides symmetrically. Impaired sensation puts them at high risk for skin breakdown.
Motor function, the cerebellar part.
This assesses coordination and balance. Have them do rapid alternating movements like tapping fingers or feet, the finger to nose test, heel to shin test, check balance with the Romberg test, stand with feet together, eyes open then closed, watch for swaying, standing on one foot and tandem walking, heel to toe.
And reflexes.
Deep tendon reflexes, DTRs, are tested by tapping a tendon briskly with a reflex hammer, causing muscle contraction. Common ones are biceps, triceps, patellar, knee jerk, Achilles. Grade the response on a 0-4 scale, 0 no response, 2 plus normal, 4 plus hyperactive clonus. Reflexes might be diminished in older adults or hyperactive with certain conditions or substance use.
Final teaching points for neuro.
Safety is paramount if there are sensory or motor deficits, ensuring they use glasses, hearing aids, walkers correctly. Pacing activities for older adults. Regular skin inspection, especially if pain sensation is reduced. Wow. That was a comprehensive deep dive. It really shows how health assessment is this ongoing dynamic process, absolutely central to nursing.
It really is. We hope you'll internalize these concepts, really practice these skills. Remember, every single assessment is a chance for critical thinking, for advocating for your patient. Knowledge is great, but it's most valuable when you understand it deeply and can actually apply it.
Well said.
So here's something to think about. How does a single, maybe seemingly minor assessment, finding a subtle change you notice when you combine it with your understanding of the body systems in that patient's history? How can that one cue become the key to preventing a major health crisis down the line?
That's a powerful thought. Thank you so much for joining us on this deep dive today. We're glad to have you as part of our learning community. Keep practicing.